What if I told you that treating a prolapsed pelvic organ doesn't actually start in a surgical suite,
Right.
but rather with, like, a footstool, a bowl of oatmeal, and, a cough drop?
It sounds totally wild, but it's true.
Yeah. Today we are completely flipping the script on pelvic health. Welcome to the deep dive. Our mission today is to decode the actual physical mechanics of the pelvic floor and specifically uncover those everyday lifestyle changes that act as, well, pressure relief valves for your vaginal support tissues.
And to do that, we're analyzing a massive, highly authoritative stack of sources. I mean, we are looking at current medical guidelines from the National Institute for Health and Care Excellence, deep clinical guidance from the Royal College of Obstetricians and Gynecologists, numerous NHS Trust leaflets, and comprehensive updates from the British Menopause Society.
It is a mountain of data, but the most empowering takeaway from all of this research is that when people hear pelvic organ prolapse or, pelvic floor dysfunction, they usually assume the only fixes are surgery or just living with the discomfort.
Exactly. But the most effective first-line treatments are actually everyday habits. We're talking about the biomechanics of how you sit, how you lift things, and literally how you breathe.
Okay, let's unpack this, because before we get into those daily habits, we need a clear anatomical picture. What are we actually trying to protect here?
Well, visualize your pelvic floor as a dynamic trampoline stretching across the entire base of your pelvis. It's this complex hammock made of muscles, fascia, and ligaments.
Okay.
And its primary biological job is to act as a supportive shelf for the heavy organs sitting right above it. So that's your bladder, your bowel, and your uterus.
And when those support tissues weaken or stretch or tear, those organs basically lose their shelf, right?
Yeah.
They begin to bulge downward into the vaginal space, which is what we call a prolapse.
Right, and the absolute ultimate enemy of that trampoline is downward pressure. Any force that pushes down into the pelvic bowl tests the structural integrity of those ligaments.
Makes sense.
Over time, relentless downward pressure causes the collagen fibers in those tissues to fatigue and stretch. It's much like an overused rubber band that just loses its snap.
So to protect the trampoline, we first have to identify every single force pushing down on it from above.
Exactly, which brings us to a vital clinical concept called the pressure stack. To truly manage pelvic floor strain, you cannot just look at the pelvis in isolation. You have to evaluate the invisible, compounded loads pushing down through the entire torso. And surprisingly, the very first place the medical guidelines tell us to look isn't below the belt. It's in the lungs.
Okay, wait. I find it hard to believe a cough can cause a structural collapse in the pelvis. Are we overstating that link?
It sounds like a leap, I know.
Yeah, it seems like a massive leap to say a respiratory issue is a primary driver of a gynecological condition.
Well, it's counterintuitive until you look at the physics of human respiration. Your abdominal cavity is essentially a sealed cylinder. The top of the cylinder is your diaphragm. The bottom of the cylinder is your pelvic floor.
Okay, I'm visualizing the cylinder.
Right, so when you cough, your diaphragm forcefully and violently spasms downward to expel air from the lungs. Because the cylinder is sealed, that massive spike in intra-abdominal pressure has to go somewhere.
Oh, wow.
Physics dictates it will follow the path of least resistance, which is straight down into the pelvic trampoline.
So every single cough is a blunt force mechanical impact on those ligaments.
Yeah, but a single cough is easily absorbed. The clinical danger lies in the relentless, repeated pattern of pressure. Chronic coughing, whether that's driven by asthma, seasonal allergies, or a chest condition, is officially recognized by the NHS as a major progressive risk factor for prolapse.
So treating a prolapse isn't just a gynecological issue, it's a respiratory one. It's like trying to fix a leaky roof while someone is literally jumping on the ceiling above you.
That is the perfect analogy. The pelvic floor simply never gets a recovery period. It's constantly under siege. What's fascinating here is how treating the chest issue is literally part of the pelvic care plan. Reducing the source of the pressure is just as important as strengthening the muscles below.
That reframes things completely, which I guess is why the medical literature places such a heavy emphasis on smoking cessation.
Absolutely. Stopping smoking is a critical lifestyle change. Smoking is intrinsically linked to the smoker's cough, which provides that daily mechanical battering we just talked about.
Right.
But it's also a double threat. Beyond the mechanical trauma, smoking acts as a severe systemic disruptor to the tissues themselves.
The sources highlight that smoking impairs wound healing, which is critical if someone eventually requires surgical intervention.
Yeah.
But there's a more insidious chemical process happening too, specifically regarding hormones, isn't there?
Oh, yeah. The biochemical impact is profound. Smoking actively increases the liver's metabolism of estrogen. It essentially causes your body to clear estrogen out of your bloodstream at a much faster rate than normal.
And estrogen is vital for tissue elasticity.
Exactly. Estrogen is the primary hormone responsible for stimulating fibroblasts, which are the cells that produce collagen and elastin in your vaginal tissues.
So less estrogen means a direct reduction in the structural building blocks. The tissues literally become thinner and weaker.
Yeah, so stopping smoking stops the mechanical pounding of the cough, it preserves the estrogen needed for elasticity, and it helps wound healing.
Okay, so if coughing from the lungs is essentially hammering the pelvic floor from the top down, we naturally have to pivot to the other massive source of internal pressure, the digestive tract.
Right. Chronic constipation and the act of repeated straining on the toilet are universally flagged across the NICE-E guidelines and the RCG frameworks as primary triggers for prolapse.
When you strain to pass a bowel movement, you are forcefully directing that pressure against the vaginal walls,
Right, and severe straining frequently leads to a specific type of prolapse called a posterior wall prolapse, or a rectocele.
which is where the rectum actually pushes forward into the vagina, right?
Exactly. The structural fascia weakens and the rectum bulges into the vaginal space, creating a physical pocket,
And then stool can get trapped in that pocket.
which makes it incredibly difficult to completely empty the bowels, leading to, you guessed it, more forceful straining. It's a devastatingly effective vicious cycle.
So breaking that cycle requires highly specific dietary lifestyle changes to avoid straining altogether. The guidelines universally recommend aiming for 1.5 to 2 liters of fluid daily.
Yes.
But the guidance on fiber is where we need to look closer. They suggest 18 to 30 grams of fiber a day, but the sources draw a strict line between insoluble fiber and soluble fiber.
That distinction dictates how your digestive tract functions. Insoluble fiber, which is found in things like wheat bran, acts like a broom. It sweeps through the gut and adds bulk to the stool.
But if you only add bulk without softening that mass, you're just creating a larger, harder object that requires immense pressure to path.
Exactly, which is a nightmare for a weakened pelvic floor.
So if I'm listening to this and I want to soften things up without experiencing constant bloating, how do I actually implement that? Because eating a ton of bran all at once is awful.
Right. The clinical answer is soluble fiber. Foods like oats, pears, and kiwis contain fiber that actively binds with water in the digestive tract. It forms a viscous, gel-like paste.
A paste?
Yeah, this gel prevents the colon from extracting too much water from the stool, keeping it soft, lubricated, and easy to pass without any manual force.
And the NHS sources specifically recommend a gradual approach, right?
Yeah.
Highlighting one highly effective trick, adding ground flax seeds or linseeds gradually to a morning meal.
Yeah, alongside a hot drink, like honey and lemon in hot water, first thing in the morning. The hot liquid stimulates gut motility, while the linseeds provide a high dose of that gel-forming soluble fiber.
But modifying the stool itself is only half the equation. The physical mechanics of how and when you use the bathroom dictate the rest of the pressure stack.
This is where it gets into behavioral lifestyle changes. You shouldn't just rely on conscious willpower or sit on the toilet at random times. You need to hijack the body's autonomous nervous system.
Specifically something called the gastrocolic reflex.
Exactly. It's an involuntary physiological response. When food enters your empty stomach, receptors detect the stretching. They send the signal down to your colon, essentially telling it to contract and clear out old waste to make room for the new food.
It's an automated clearing system.
And it is biologically strongest roughly 30 minutes after eating breakfast. The clinical advice is to sit on the toilet during this precise window. You allow the colon's muscular contractions to move the waste downward, completely eliminating the need for you to push.
Here's where it gets really interesting, though. When you do sit down, posture is everything. The NHS provides a very specific diagram for optimal toilet posture, and it completely contradicts the standard Western toilet design.
Oh, completely.
You are advised to use a small footstool so your knees are elevated above your hips. You lean forward, resting your elbows on your knees, and intentionally bulge your abdomen outward.
That specific posture directly manipulates the internal anatomy, specifically a muscle called the puborectalis.
So I picture this like optimizing the plumbing angles in a house. If you sit upright at a 90-degree angle, like in a normal chair, the puborectalis muscle stays somewhat engaged. It pulls the rectum forward, creating a sharp kink in the anatomical hose to maintain continence.
That is the perfect analogy. As long as that kink is there, you have to generate a massive amount of downward pressure to force waste past the bend.
Right.
But when you use a footstool and elevate your knees, you mimic a deep squat. This fully relaxes that puborectalis muscle. The rectum straightens out, the kink is removed, and gravity is able to do the work instead of forceful pressure.
By simply adding a footstool, you're removing a major daily trauma to the pelvic organs.
Hmm.
It's such a tiny tweak for a massive structural payoff.
It really is.
So that covers the internal pressure from the lungs and the gut. But we also have to evaluate the external loads, our own body mass, and the objects we interact with.
Yeah, the medical guidelines are unequivocal on the impact of physical mass. A body mass index over 25, and particularly over 30, acts as a constant, non-negotiable external weight pressing down on the pelvic organs. Gravity does not take days off.
Right.
The clinical evidence demonstrates that losing weight directly relieves symptoms of urinary incontinence and mild prolapse simply by reducing the physical burden the trampoline has to support.
I'm going to challenge the practical application of that advice, though, because the guidelines tell patients they need to lose weight to save their pelvic floor. Yet, in the exact same breath, high-impact exercises like trampolining, running, or HIE are explicitly forbidden because they worsen prolapse symptoms.
I know.
How is a listener supposed to lose weight if they are banned from the most common forms of intense cardio?
That frustration is incredibly common. The key is understanding ground reaction forces. When you run, every single time your foot strikes the ground, a shockwave equivalent to 2 or 3 times your body weight travels straight up your legs and directly into the pelvic bowl. Yeah, if the ligaments are already compromised, those repetitive shock waves will cause further tearing.
So the goal isn't to stop exercising, it's to swap high impact for low impact.
Precisely. That's the lifestyle pivot. Swimming, cycling, fast walking, Pilates, and yoga are heavily endorsed. In a pool or on a bike, your body weight is fully supported. You get the cardiovascular and weight loss benefits without the repetitive downward loading on the pelvic floor.
It requires becoming deeply symptom-aware in how you move. And that extends to modifying daily activities, too, like heavy lifting.
Oh, absolutely. We tend to think of deadlifting barbells, but everyday activities are just as damaging. Carrying heavy shopping bags in both hands for a long walk, or wearing a front-loaded baby carrier shifts your center of gravity.
And that external mass pulls directly downward.
Yes, creating sustained tension on the vaginal support tissues. So the advice is to use a wheeled cart for groceries or a stroller instead of a wearable carrier to protect against prolonged strain.
Okay, so we've mapped out a comprehensive defensive strategy. We treat the cough, fix the diet, use a footstool, and change our workouts. We're minimizing the pressure stack at every turn.
Right.
But we can't avoid all pressure. We still sneeze unexpectedly. We still have to stand up or occasionally lift things. How do we actively defend the tissues in those unavoidable moments?
This is where the strategy shifts to active defense. The clinical intervention for this is a highly specific, clever body skill known as the knack.
It sounds like a secret technique.
Yeah.
What is the actual mechanism behind the knack?
The knack is the conscious, intentional contraction of the pelvic floor muscles, timed exactly right before and during any pressure event. You perform a gentle, strong pelvic squeeze a split second before you sneeze, right before you cough, or as you are bracing to lift an object.
It makes complete mechanical sense. It's like bracing yourself and tapping the brakes right before your car hits a pothole, rather than just letting the suspension take the full, unexpected impact.
Exactly. You stiffen the structural hammock to hold the uterus and bladder in place before the shockwave hits. But for the knack to be effective, your pelvic floor muscles need reflex speed and endurance. That requires structured pelvic floor muscle training, or PFMT.
And the sources outline an exact routine for this. It's not just squeezing randomly. It targets different muscle fibers.
Right. The routine has 2 parts. The first is 10 fast lifts. You squeeze the pelvic floor fast, holding for just 1 second. This trains the fast twitch muscles.
Those are the ones responsible for instant reflex reactions, like snapping shut when you sneeze.
You got it. And then the second part is 10 slow lifts. You do a gentle pull and try to hold it for up to 10 seconds before a slow release. This targets the slow twitch fibers, which build endurance for all-day organ support.
And the consensus recommends doing this routine of 10 fast and 10 slow lifts 3 times a day.
Yes.
Okay, we've talked a lot about the muscles beneath the tissues, but I want to ask about the actual physical quality of the vaginal tissues themselves. As listeners age, the biochemical makeup changes.
It does. The British Menopause Society provided a deeply comprehensive look at genitourinary syndrome of menopause, or GSM. As estrogen drops during menopause, the cellular architecture degrades.
The tissues lose collagen and elastin.
Exactly. The vagina loses its natural thickness and moisture. The tissues become significantly less pliable, vastly more fragile, and highly prone to micro-tearing under normal daily pressures.
So, beyond pelvic floor exercises, how does someone actively maintain the health and elasticity of the actual vaginal tissue?
Well, if we connect this to the bigger picture, the British Menopause Society includes a surprising lifestyle recommendation for tissue preservation: regular sexual activity.
Wait, really? I imagine many people assume thinning tissues means they should avoid mechanical friction entirely.
It's a common assumption. But regular sexual activity, which includes intercourse or using vaginal dilators, provides massive benefits. First, arousal triggers an influx of oxygen-rich blood to the vaginal mucosa, delivering vital nutrients. Second, the physical act provides mechanical stretch.
It's essentially physical therapy for the vaginal walls.
Yes. When those cells are subjected to regular, gentle mechanical stretch, they are stimulated to produce more collagen and elastin. It helps maintain elasticity, which actively prevents the progression of tissue atrophy. Use it or lose it literally applies here.
That is fascinating. We have covered immense ground today. Let's pull all this together for the listener.
Yeah, let's do it.
If you are listening to this and you've been diagnosed with a mild prolapse, or you are noticing early signs of pelvic floor weakness, the overarching message from all this clinical data is that risk is not destiny.
No, not at all. A mild prolapse doesn't mean your active life is over. It just means your life needs to be more symptom aware.
Exactly. By managing the pressure stack, by treating a chronic cough, using a footstool, modifying workouts to low impact, and mastering the knack, you're taking profound active steps to preserve your anatomy.
Reviewing the sheer biomechanical logic behind all of these everyday interventions actually leaves me with a pretty provocative thought to ponder.
Oh, where does the data lead us on that front?
Well, consider the anatomy of the footstool and that puborectalis muscle we discussed. If simply changing the angle of our knees on the toilet can so drastically reduce the physical trauma to our internal organs, it raises a profound question.
Okay.
How much of our modern environment is actually working against our evolutionary anatomy? From the design of standard Western toilets to the way we sit in ergonomic office chairs all day, what other accepted modern conveniences are secretly sabotaging our foundational health simply because they were engineered for aesthetics rather than biological function?
Wow. Are we living in an environment designed to support our anatomy, or one that passively dismantles it? That is an incredible lens through which to view our daily habits. Thank you so much for joining us on this deep dive into the mechanics of pelvic health. If you found these insights valuable, please share this deep dive with anyone in your life who might benefit from understanding just how much control they truly have over their foundational well-being. Until next time.